Thank you again to Dysautonomia International for inviting me to speak, and it's a privilege to be here this morning, early Sunday morning, to speak about autonomic disorders. What I hope to talk about today is autoimmunity and mast cell activation syndrome and POTS dysautonomia. I hope to do a number of things, talk about the evidence for and clinical features of autoimmune conditions and dysautonomia, to speak about different disorders that have been associated with autonomic dysfunction, POTS dysautonomia, and to review the clinical features of mast cell activation syndrome. The real title of my talk is 5 Things I Think I Know About Autoimmunity and Mast Cell Activation in POTS, but I reserve the right to be wrong. I'm wrong a lot. Just ask my 16-year-old daughter, who tells me I'm wrong every day. You don't understand, Dad. I guess the other thing I'd like to say is, I mentioned yesterday I'm a clinician, not a scientist, and being a clinician in this area, really, I think it's about 3 things. One is an art. Medicine is an art. Second, there's faith. So by that I mean you have an intuition, gut feeling, instinct about things, the right things to do, and you take a leap of faith. The third thing is science. We don't have enough science in this area. That's what this conference is about increasing our knowledge, expanding our knowledge, increasing science so that we can make treatment decisions, evaluate patients, take better care of you all with science. Art and faith is still important, but hopefully science will improve. So first thing that I think I know that I'll be talking about, POTS begins as an autoimmune condition in many, and I'll talk about the evidence and why I think that. Second, a number of hereditary and acquired factors may increase a patient's risk of developing POTS. In POTS patients, autonomic nervous system remodeling occurs, in my opinion, and in patients with chronic, persistent, refractory symptoms, remodeling may be maladaptive, and it may actually stimulate autoimmunity, cause the immune system to misbehave. Sjogren's syndrome may be the most common secondary cause of POTS. It may. I'll talk about Sjogren's syndrome. And finally, mast cell activation syndrome is very common, sometimes difficult to diagnose, at least if you use laboratory studies, but it's treatable, and we should be paying attention to it. So, POTS begins as an autoimmune condition in many. The evidence for that dates back to the first case reports of POTS, and this was from Dr. DaCosta, who described POTS back in 1871 at the time of the Civil War. So a man 3 months or so on active service was seized with diarrhea. Annoying yet not so severe, soon rejoined and then noticed that he could not bear exertion as well as formerly. Out of breath and unable to keep up with his comrades, dizziness and palpitation, accoutrements oppressed him, yet otherwise he seemed well and healthy. Sought advice, was sent to hospital, where his persistent quick heart confirmed his story. Digestive disturbances, if present, passed away, if only, but the irritable condition of the heart remained, and only very slowly did this get normal, or it failed to do so. So, aside from being very well written, I wish I could write that well, the story begins with diarrhea, which may very well have been a GI bug, a gastroenteritis, hard to know, but in this case report, it was presumably a viral GI bug infection that triggered this condition. And so this has been reported over and over again. So Dr. DaCosta first described this in 1871, observed this in American Civil War soldiers, but recognized that it occurred in civilians. A little bit later, a long time ago, again, this condition that they called irritable heart, in 30% of their patients, a preceding infection seemed to trigger the condition. The introduction of the term POTS in 1993, based upon a description of 16 patients with POTS, 7 of 16 had a preceding viral illness. So POTS may start after an infection. So what? What does that mean? Well, there is a condition called acute autoimmune autonomic neuropathy. This is not POTS, but the story here is important, and I think there are some important lessons to learn from the condition. So this condition, like POTS, may arise in a post-infectious setting. It's thought that this condition is an autonomic form of Guillain-Barre syndrome. Guillain-Barre syndrome is a neuromuscular condition where patients develop numbness, weakness, may end up on a ventilator due to neuromuscular involvement. In this condition, the autonomic nerves take the brunt of the damage, and these patients end up with autonomic failure. It's suspected that this is an autoimmune condition, and we treat these patients with IVIG and plasma exchange. So in the first description of POTS, in those 16 patients from the Mayo Clinic, the conclusion in this abstract was that in many instances, POTS may be a manifestation of acute autonomic neuropathy. So not fulminant autonomic failure, where patients cannot get out of bed due to recurrent syncope, but a more limited, attenuated form that arises in a post-infectious state. I reported this case a few years ago that I thought was important. This was a 36-year-old female, actually a sister of a neighbor, a physician in Scottsdale. She's communicating to me from South Africa. She was pregnant, had a miscarriage, and then an infection. She developed thoracic, so pain across her trunk, difficulties with urination. And when I was communicating via email to South Africa, I thought, well, certainly this is a spinal cord problem. Sounds like a spinal cord problem. And so ultimately, she traveled on an airplane 30 hours and came to our hospital in Phoenix. And she was admitted to hospital, had a number of studies, spinal tap, imaging studies, everything came back normal. She was diagnosed with an adjustment disorder, and of course, the folks on the hospital service said, well, we'll send her to Goodman, he can deal with it. So after speaking with her in person, there's no substitute for speaking with patients in person, getting the flavor of the story, then performed autonomic testing, and up top is tilt table testing. The green, hopefully it looks green, is heart rate, and you can see that heart rate increases more than it should with the tilt up. In red is blood pressure. That's a typical profile of what we might see with POTS. At this point, she was about 3 weeks or so into her illness. So this was her tilt table following treatment. So I treated her initially with methylprednisolone, then with IVIG, and this was her tilt table study a few weeks later. So I don't know whether she would have gotten better on her own. I don't know that, but it was gratifying when she went home about 3 weeks later to South Africa completely normal, with having come with a disabling set of symptoms. So my interpretation of that case was not that she had adjustment disorder, but that there was an infection, or perhaps pregnancy, which triggered an immune response, an autonomic neuropathy that was immunoresponsive. When someone experiences an infection, the current theory of how this creates an autoimmune condition is an idea of molecular mimicry. And in the cartoon is a bacteria above and a component of nerve membrane below. And essentially, components of the bacteria resemble components of the nerve membrane. And the body's immune system does not distinguish those as being different. So the body is tricked into thinking that by the bacteria or whatever infectious agent, this part of the nerve membrane is abnormal and needs to be attacked. And this is the idea of molecular mimicry. In this example, this is Campylobacter in Guillain-Barre syndrome. So Campylobacter bacterial illness typically results in gastrointestinal symptoms acutely and may result in Guillain-Barre syndrome. I'm struck by this condition called polyglandular autoimmune disease. I know very little about it, so don't ask me about it, please. But it has a lot of similarities, I think, and may be a way of thinking about the mechanisms of how different systems are involved in autonomic disorders. So in these conditions, basically, there are autoantigens in the thyroid, the adrenal glands, and these autoantigens are become a target, and these organs fail as a result of this autoimmune state. So potentially a way of thinking about what we are seeing clinically. So besides infection, there are other conditions that I think may trigger an immune response which can affect the autonomic nerves. We see this after surgery or a procedure. It can be anything. I've seen it after foot surgery, after abdominal surgery. It's not uncommon after cholecystectomy. Pregnancy, we see POTS symptoms arise during pregnancy, after pregnancy. Is that autoimmune? Is that endocrine, hormonal? I don't know for sure. My suspicion is more along the autoimmune lines, and then immunization may potentially trigger an autoimmune condition affecting the autonomic nerves. Second point, a number of hereditary and acquired factors may increase an individual's risk of developing POTS. So I think about the development of POTS as an accumulation of risk factors. Again, I reserve the right to be wrong, but this is how I think about it. And this is not meant to be a complete list. This is just trying to fit in enough circles onto a PowerPoint slide for the major things that we might see. But I think that these are the major players. So autoimmune, I've talked about. I'll talk about a little bit more. Ehlers-Danlos syndrome is, from my perspective, as I stand here, certainly a major risk factor for developing POTS. Head trauma, concussion, I'll be talking about as a risk factor for developing POTS. There are genetic factors, undoubtedly. We have a wonderful study taking place here now to look at genetics. Deconditioning certainly may be a factor in the development of POTS in some patients. There are toxic conditions that we worry about, and migraine, new daily persistent headache, may be a risk factor for developing POTS. So as I see these things, most of the patients that I see have some combination of these things. These are not mutually exclusive. So I've seen patients with Ehlers-Danlos syndrome, a mitochondrial disorder, chronic migraine, and POTS. That same patient may be at risk for an autoimmune condition. So this, in my opinion, is an accumulation of risk factors that leads to this heterogeneous syndrome. Head trauma causes autonomic dysfunction. I'm going to talk about that a little bit. So the first reported case of brain injury and resulting dysautonomia was attributed to Penfield, famous neurosurgeon, who in 1929 described autonomic dysfunction in a patient with a tumor deep in the brain in the third ventricle. And this patient developed irregular breathing, hiccups, and lacrimation, and called this diencephalic epilepsy. Now, this really isn't epilepsy, but this is autonomic dysfunction, which they term diencephalic epilepsy. And that term actually has, unfortunately, stuck around longer than what it should, but we don't call autonomic dysfunction with brain injury by diencephalic epilepsy any longer. But the first case associated with traumatic brain injury was by the same neurosurgeon, Dr. Penfield, 25 years later. 19-year-old man, traumatic brain injury, who experienced episodes of tachypnea, tachycardia, hypertension, and hyperthermia. So tremendous autonomic instability triggered by a traumatic brain injury. Since that time, there have been a number of reports of autonomic dysfunction in traumatic brain injury. There have been very few in concussion, more on that in a moment. These different reports have called the autonomic dysfunction in traumatic brain injury by a number of different terms listed here: sympathetic storm, dysautonomia, autonomic dysfunction syndrome. So how about concussion? There's very little evidence in the literature, at least. So this was one report from a military report of syncope in 2 soldiers who had an IED explosion and a resultant concussion that was presumed to have resulted in their autonomic impairment. Several years ago now, I guess 4 years ago or so, maybe 5 now, we became interested in autonomic dysfunction and concussion. I became interested in it a long time ago when I was seeing POTS patients, and said, gosh, some of these POTS patients seem an awful lot like the concussed patients that I see. So finally, once our concussion center got up and running, my friends Dr. Vargas and Dr. Dodick and I looked at a series of patients who were going through our concussion clinic at Mayo, Arizona, and we looked at the prevalence, pattern, severity of autonomic impairment in these patients. So we looked at 20 consecutive patients. We've had a lot more patients go through our lab now. And we reviewed their clinical features, laboratory features, autonomic findings, and everybody had an MRI scan. So 20 patients, a wide age range, and the median time from concussion to our evaluation in the Autonomic Lab was 37 days. All had headaches, and the headaches were severe in almost all of the patients. And interestingly, patients experienced an excessive postural tachycardia, very similar to POTS, perhaps identical to POTS in some. Patients also had an unstable, fluctuating blood pressure. I'll show some pictures in a moment. But the interesting part of this to me was, if you talk to someone who's had a concussion, and probably there are a number of people in the room who've suffered from concussion, People talk about dizziness. As neurologists, everyone has assumed that this dizziness results from vestibular inner ear problems. There's often is a component of spinning, but people assume that without delving into what characteristics of dizziness patients were reporting. And in fact, many of the patients actually reported lightheadedness. Interestingly, 3 of the patients actually had syncope when they were so they were fainting when they underwent our testing. So again, further evidence of autonomic dysfunction following concussion. This is a slide of a professional hockey player, and he had unfortunately been involved in too many fights. Some of them you could see on YouTube. They were nasty looking injuries, and you can see in green the heart rate. This is a conditioned athlete, so there's no deconditioning here. Heart rate is low, supine, but increases excessively when we tilted him up. Also, you can see in red, blood pressure is very unstable. This otherwise healthy person, highly conditioned professional NHL hockey player, developed blood pressures into the 200s, then dropped blood pressures down into the 110s systolic, so tremendous autonomic instability. This patient had the most severe autonomic dysfunction that we saw in our group, and this actually correlated. He was the only one with an abnormal MRI scan. Here's another patient. Again, a highly fit athlete. You can see a resting heart rate of 40 beats per minute. So not deconditioned, and heart rate with just a tilt goes up into the, I believe, what is that, 100 range or so with head-up tilt. So about a 60 beat increase in heart rate with tilt table testing. So autonomic dysfunction is common in concussion. It's under-recognized. We as neurologists do a horrendous job recognizing that. The autonomic dysfunction in concussion resembles POTS. It may be identical to POTS, but certainly we see POTS begin in some following concussion. Next point, headache is important, also ties into concussion. But headache is important in POTS, and treating it is important, and I think characterizing headache is important. We've learned from Dr. Kinsella that it's important to make sure that patients don't have a cerebrospinal fluid leak, particularly patients with Ehlers-Danlos syndrome are at risk for that, but it's important for us to characterize the type of headaches that are occurring in patients with POTS and to treat them. So a postural headache, in my clinic at least, is uncommon. This can mimic a CSF leak, a leak of spinal fluid, or may actually result from a cerebrospinal fluid leak. It's also not uncommon for POTS patients. Probably a number in the room will experience an exacerbation in headaches with exercise. I think this is a wonderful study, underappreciated study of headache in POTS. Interestingly, so these authors looked at headache in 24 POTS patients. The headache started at the same time as POTS in 7 of the patients, followed it in 6. 56% in their group was exacerbated by standing, and migraine was very common in this group. I've had interest in this area, and unfortunately I don't have statistical analysis yet. We're working on that, but what I learned from studying headache in a cohort of my patients with POTS is that headache is important. And so what I wanted to show with this slide is that in patients with chronic migraine, for example, so this is headache greater than 16 days per month, that correlates with increasing scores of autonomic severity. So the COMPASS, which is our autonomic scoring system, scores are increased with chronic migraine. An illness intrusiveness scale, which gives us an estimate of how bad this condition is affecting our patients, those scores were much higher with chronic migraine and this new persistent daily headache. So headache is important. It's important to recognize, and it's important to treat. Third point. I may very well be wrong about the third point, but again, I reserve the right to be wrong. In POTS patients, I think that autonomic nervous system remodeling occurs, and in patients with chronic persistent refractory symptoms, this remodeling may be maladaptive. So I certainly have a lot more gray hair now than I did 3 years ago. The autonomic nervous system in someone that I'm seeing 6 months out from symptom onset may look very different from how that autonomic nervous system looks 3 years out. So it's important to recognize that these systems are changing all of the time. So it's important to reevaluate things, and I think it's really important sometimes to retest, and particularly in individuals where symptoms are chronic, persistent, refractory. So I think remodeling occurs, and we need to pay more attention to it as providers. This was a study from Dr. Sandroni out of Mayo Clinic, Rochester, looking at outcomes in patients with POTS. And 80% of patients in this series improved. So, begging the question, why are some patients with POTS improving? Why are some not? Why do some people get back to normal? Why do some not? That's a critical question. I wish I knew the answer to that. Here's a case of someone who got better. The top part of the slide is tilt table testing in a patient who I saw with very typical POTS, treated in the usual measures with lifestyle measures and midodrine. And about a year later, she was markedly improved. Tilt table testing was considerably better. I wouldn't consider it normal, but considerably better. And she was nearly symptom-free. So this patient got back to normal. This patient is not back to normal. This patient, you can see up top, has a tilt table testing which shows in green a really fast heart rate. In red is blood pressure, and you can see that blood pressure is all over the place. It's very unstable. It has what we call oscillations. I personally believe that the brain does not like those oscillations, and that may be the reason for some of the symptoms that people have. The autonomic testing down below is in the same patient, who again is no better, and you can see that it's interesting, the heart rate perhaps doesn't increase as much, but we see blood pressure going up. This patient was taken off of medications for the study. So our interpretation of this patient is that the autonomic nervous system evolved. It may have evolved in a maladaptive way, but that evolution may be important. We need to pay attention to that. Here's another case. Up top is, so this is a 16-year-old patient of mine, a daughter of a Mayo employee, one of my sickest patients, wheelchair-bound, fainting multiple times a day. Fortunately, I saw her about 3 months into her condition, and you can see here, first of all, we weren't able to tilt her for very long. This was about 2 minutes, and she passed out. But interestingly, hopefully, maybe hard to see, but to the right is cuff measurements, and you can see that she was very hypertensive when we tilted her up. And then down below, the other part of this is below the tilt table testing is her sweating was impaired. So in yellow, you see that the bump isn't as high, so that's sweating in the foot. So I interpreted her case, which again started after an infection, as being hyperadrenergic and neuropathic. And so she was doing horrendously. Ultimately, I treated her with immune therapy and still am. And you can see down below that hypertensive response with tilt table testing has lessened and her sweating improved. Now she, at this point, was still in a wheelchair. So one of the questions I've heard, well, what is hyperadrenergic POTS? How do we diagnose it? What does it mean? Is it a bad prognostic sign? I don't know the answers to those questions. I've been suspicious. Again, I may be wrong, but I think that hyperadrenergic condition in POTS may reflect maladaptive remodeling of the autonomic nervous system. The other big question, I think, is could this lower the threshold for the development of autoimmune disorders? So in patients where the autonomic nervous system is continuously revved up in a maladaptive way, is this pro-inflammatory? Does this trigger an autoimmune state? There probably is more evidence for that than what I'm aware of. In fact, of a revved up autonomic nervous system being pro-inflammatory. But this was an interesting study on rheumatoid arthritis suggesting that chronic stress may exert pro-inflammatory effects. So potentially something for us to think about. So these days, I really strive to stabilize that autonomic nervous system because I think that that's important from an immune standpoint in hopefully preventing the development or mitigating autoimmune conditions. Fourth point, Sjogren's syndrome may be the most common secondary cause of POTS, but other autoimmune conditions are associated with autonomic nervous system dysfunction. Dr. Schofield, who's taught us all about antiphospholipid antibody syndrome and the importance of recognizing that in autonomic disorders, will be speaking later this morning. Lupus is very uncommon in my experience. I'm not convinced at this point that celiac disease causes autonomic dysfunction. It certainly is seen at a high prevalence in patients with POTS, but I certainly have not seen autonomic dysfunction improve when I diagnose celiac disease and patients go on a gluten-free diet. I've seen POTS with rheumatoid arthritis. So Sjogren's syndrome characteristically affects the eyes and the mouth, causing dry eyes and dry mouth, but it's recognized that there are extraglandular manifestations of this condition in a lot of patients. So this is considered a rheumatologic disorder. I've argued that the neurologists need to put on their big boy and their big girl pants and claim this condition because the primary, most common disabling features of Sjogren's syndrome are neurological. So these days, I I don't send patients to rheumatology. I'll treat in the fashion that I deem necessary or indicated as a neurologist. There are different forms of autonomic nervous system impairment that have been described in Sjogren's syndrome, can be associated with autonomic neuropathy, can look like POTS, and patients can have autonomic failure. Unfortunately, our laboratory studies lack sensitivity at best. They're 50% sensitive. I'm not sure I think that's being gracious. The other difficult part of this is autonomic symptoms may precede dry eyes and dry mouth. So POTS symptoms may begin prior to dry eyes and dry mouth developing. And we should have a low threshold for performing a minor salivary gland biopsy. It's been suggested that patients with Sjogren's may have autoantibodies against muscarinic receptors. These receptors are on salivary glands. Dr. Vernino, who's here this weekend, has looked actually at muscarinic antibodies in POTS patients and found actually a high percentage in patients. Preliminary work, but bottom line is that there may be antibodies that are important against these muscarinic receptors. This is our case series, recently came out, of Sjogren's syndrome, describing POTS in a cohort of patients with Sjogren's syndrome. And notably, patients had lightheadedness, syncope, near syncope, and prominent GI symptoms, and peripheral neuropathy was present in some. This is by neurological examination and EMG, but not all patients. And this is just more for slide purposes, but this is what testing showed in this cohort of patients. So again, a wide range of autonomic impairment can occur in Sjogren's, and GI testing is frequently abnormal in Sjogren's syndrome. So this is autonomic testing in a Sjogren's syndrome patient. Again, showing in green an excessive increase in heart rate, unstable blood pressures. Here's another one showing a collapse in what we call a collapse in pulse pressure. The blood pressure narrows. I'm sure many of you have seen that when you've checked your own vital signs, the narrowing between the systolic and the diastolic pressures, and then an increase, a large increase in heart rate with tilt table testing. So the way that I approach POTS and Sjogren's syndrome at this point is, as I alluded to earlier, attempt to stabilize the autonomic nervous system through lifestyle measures and pharmacotherapy. I don't immediately put everyone on immune therapy, nor do I think everyone should be put on immune therapy. It's possible to control the condition with lifestyle measures, pharmacotherapy, and by that I mean blood pressure supporting medications in some patients. I have some patients who are doing well, not on immune therapy. I do think it's important. So mast cell activation syndrome, which I'll talk about next, if I don't get kicked off the stage for being late, is very common in Sjogren's. Unfortunately, the laboratory testing is often negative, but I have nearly all of the patients that I'm currently seeing with Sjogren's on mast cell treatment, even though most of them don't test positive for having mast cell activation syndrome. Dietary modifications are important. I'm a big believer in avoiding things that may trigger an immune response in the body. For patients who don't respond to those measures, immune therapy should, in my opinion, definitely be considered. In patients who have chronic, persistent, refractory, significant symptoms, and we've primarily used IVIG for that purpose. So, a bit about mast cell activation syndrome. I like this slide. I stole it off of Google, disclosure. I like it because it just points out, hey, these mast cells are everywhere and they can wreak all sorts of havoc, and we should be taking it seriously. I think the other point is that mast cells, in my opinion, may be very regional. So if you think about the testing, we're testing a blood level of tryptase, urinary mediators. Those are going to be abnormal if mast cells everywhere are dysfunctional. They may not necessarily be abnormal if you have a bunch of mast cells that are misbehaving in the gut. So this may be more regional. It may be primarily in the bladder. It may be primarily in the GI system. So it's important to keep in mind as physicians, again, we should be treating patients, not laboratory studies, and this is an important example of that, I would argue. In our clinic, upwards of 1/3 of patients will test positive for mast cell activation syndrome. I definitely do agree with the Vanderbilt group who first reported mast cell activation syndrome in hyperadrenergic POTS, that it is much more common in hyperadrenergic POTS. Again, laboratory testing is suboptimal. I do laboratory testing to make sure I don't need to do a bone marrow biopsy to rule out mastocytosis. Laboratory results for mast cell activation syndrome do not predict response rates to treatment. I'll say that again. Laboratory results for mast cell activation syndrome do not predict response rates to mast cell treatment. So patients may have very high values. They may not necessarily respond to mast cell activation syndrome treatment and vice versa. So if the labs are terrible, what do you look at? Well, I pay attention to clinical clues. So from my perspective and the people that I see, it's a history of hives, urticaria, dermatographism. Itchy skin is a big one. Flushing, it's typically face and chest. Diarrhea, be suspicious. Bloating, sometimes other prominent GI symptoms. Postural hypertension, so patients who have an increase in blood pressure with standing, I'm suspicious. And I also pay attention to the bladder, so most of the time when I hear interstitial cystitis diagnosis, I'm suspicious that that's actually mast cell activation syndrome. When I hear I have to pee all the time, or I feel like I have to pee all the time and I have a urinary tract infection, I think about mast cell activation syndrome as the cause of those symptoms potentially. This is how we evaluate mast cell activation syndrome, the serum tryptase, and then urinary mast cell mediators. I personally think that it's important to treat mast cell activation. I think it has important implications for the immune system. I probably should have put a box for the immune system on this slide, but it's important to stabilize it from an immune system perspective. Autonomic instability triggers mast cell degranulation, in my opinion, and mast cell degranulation triggers autonomic instability. So what I do is I will typically use Allegra to start. I use high-dose antihistamines. I'll typically start cromolyn, use something like Pepcid and Zantac, and then at some point later we'll add in aspirin. If a patient has suggestive symptoms, despite negative testing, I will treat anyway. The other thing that I do or believe in at this point is that dietary modifications are important. It's important to avoid things which stir up mast cells, which the things that I hear about over and over again are gluten, dairy, garlic, spicy foods, other things on the so-called low histamine diet. So I think dietary modifications are very important. Headaches and mast cell is a two-way street. So improving mast cell activation syndrome, I've seen it markedly improve headaches and vice versa. I treat this very aggressively with pharmacotherapy. And so I have some patients on 3 or 4 antihistamines. So I personally think that it's important to be aggressive when treating mast cell activation syndrome. But it's important for us to recognize that in many patients, this is not the primary cause of symptoms. This is an end product. There are things upstream which are resulting in mast cell activation syndrome downstream, and it's important to remember that. And so if we're not getting any traction treating it, we have to work our way back upstream, which isn't an easy thing to do. So I was told that I had to stop, so I'm going to stop. Thank you.